Welcome everyone to our crisis intervention series. It is wonderful to have you all joining us today. My name is Sarah Adams, and I am one of the graduate students assisting on this project. Today, we are hosting the reflection, question, and answer session. This session is presented to you by the National American Indian and Alaska Native PTTC and ATTC, located at the University of Iowa. As you can see from this slide, we are part of a national network of technology transfer centers. This program is funded by SAMHSA, but the content and opinions expressed today do not necessarily reflect the views and policies of our funder. Here are a few housekeeping things to address before we start. Throughout this event, you are encouraged to post comments or questions in the chat box. You are also very much encouraged to unmute and share during our discussions. After the event, you will receive a follow-up email. Within that email, you will receive instructions on how to receive a certificate of attendance. You may also receive additional resources from today's event. At the end of today's presentation, please take a few moments to give us feedback on the event. We will share a link to the evaluation in the chat towards the end of the session. We are so thankful for your attendance today. I also want to extend my gratitude towards Monica Dreyer-Rossi, our program director, and thank you to our center director, Dr. Ann-Helene Skinstad. Our presenters today are Dr. Ken Winters, Dr. Kathy Tomlin, Dr. Jacque Gray, and Nelda Huskie. Dr. Kathy Tomlin was unable to join us at the beginning of the session, but she may be able to chime in later on in the discussion. So with that, I will hand it off to our speakers. Thank you.
Sarah, thank you. And hello, everyone. It's a pleasure to have you for our final presentation of this installment. As you know, we always conclude a particular topic area with a sharing and discussion time together. We really encourage your participation. This is more about your thoughts and ideas than the contributions from our speakers or our faculty. So we really encourage that you use the chat box or chime in with noting with the electronic hand that you are willing and interested in offering some thoughts and ideas. We have some discussion questions to encourage our sharing today. It has been a pleasure for me to have been a consultant to the center for several years and a key person as part of this educational series. I'm a researcher with most of my time spent with research colleagues at the Oregon Research Institute, but I'm based here in Minnesota and still enjoy living in the upper Midwest. I have been a researcher for many years with a big focus on adolescent substance abuse and co-occurring behavioral health issues.
Thought I muted it. Good morning, everyone. I'm Dr. Jacque Gray. I'm a Choctaw Cherokee descendant, and I'm working with the Prevention Technology Transfer Center at the University of Iowa. And I am a retired or professor emerita from the University of North Dakota after working up there for 22 years. I have worked nationally in areas of mental health, health disparities. I've done crisis intervention work since the 80s, so getting close to, 40 years? Worked a lot with suicide intervention, both here in the US and with the Maori in New Zealand. And I am a counseling psychologist by training. And it's great to be here with you today.
Good morning. I'm Nelda Huskie. Welcome to the discussion today. Jacque is a son and Schneider Tedeshkijni Bashichinkia Ani Dashnamla Dobi Betwani Dashiche. I'm looking forward to learning from all of the sharing that's going to take place today. Welcome. I will also share with you the read to you the land acknowledgement slide today. And it says we would like to take this time to acknowledge the land and pay respects to the indigenous nations whose homelands were forcibly taken over and inhabited. Past and present, we want to honor the land itself and the people who have stewarded throughout the generations. This calls us to commit to forever learn how to be better stewards of these lands through action, advocacy, support, and education. We acknowledge the painful history of genocide and forced occupation of Native American territories, and we respect the many diverse indigenous people connected to this land on which we gather from time immemorial. While injustices are still being committed against indigenous people on Turtle Island, today we say thank you to those that stand with indigenous peoples and acknowledge that land reparations must be made to allow healing for our indigenous peoples and to Mother Earth itself. And this was written by Alan, Keeley, and Sean. Thank you.
So we'll get started. Just to give you some context, this is the fourth session in this installment that is focused on addressing behavioral crises as well as emergencies that we often are faced with in a clinical setting. And it may not only involve clients, but perhaps communities. And our reflections session is an opportunity to open up a broad discussion on some of the topics that we've addressed. We have a few select discussion questions, but we also encourage you to bring questions to the group and help us engage in thoughts that are on your mind. So it's a sharing experience. And I know from the past, the faculty have always enjoyed these because we learn so much from you. Next. We spent some time talking about key topic areas. There was discussion about differences between crises and emergencies, strategies for addressing two crises that are faced by most clinicians, got a heavy focus, that is suicide and trauma. Then there was some time discussing how to be well prepared as a clinical service provider, a community worker, as well as any setting you work in, to handle crises and emergencies. Many layers get involved with that kind of discussion. You can imagine it has to do with personal and individual preparation, as well as at a clinic level or organizational level, the kind of system-wide features and aspects that need to be in place to help that clinic and the staff at that clinic address these kinds of difficult situations. And then we did spend some time talking about the value of resilience and how encouraging clients to do their best at evoking those traits so they can better cope with a crisis. But also these traits are important for clinicians in the hopes that you can be a source of strength for a client in a difficult time, and so that you can avoid burnout. Next. So we'd like to start with an activity, this time a poll, and we're interested in what might the future look like. So if there can be funding for future educational series hosted by the center here, there's a lot of topics that we could address. And so we've listed 6 of them. They also were part of a poll sometime back, so we're interested in seeing how people still feel about these 6 topics. And so I'm going to turn it over to Sarah to get us started with how to do the poll.
Yes, so you should have seen the poll. Would be wonderful because then we can save these responses for the future. So I will give you all a moment to vote on this, and then I will close this out.
A reminder, you can vote for as many as you'd like.
Votes for all of them. Can't really differentiate anything. So
I am going to leave this up for about 10 more seconds. So if you want to get your vote in, please do so. So those are our results.
Excellent. Jacque or Nelda, any thoughts on the findings?
consent principles stayed at the top the whole way through.
Yeah. Yeah, group therapy and professional principles. Very popular. Yeah. It's nice to see many of them are popular also. Any thoughts elsewhere, Nelda or the group?
These are very close, you know, like there's group therapy, there's interest in family therapy, professional ethics and consent. They're all very, there's not anyone like really standing out. They all got votes, so that's pretty good.
Yes, we could roll out a lot of more installments, couldn't we? I mean, it's nice to see that people are interested in specific clinical skills, you know, the therapy, supervision skills, interviewing skills, to help sharpen your work.
Hello.
Yes.
I'm Mike Shaving from Oak Rehab on the Shine River Reservation, and I worked in the field of alcoholism for a number of years, and I was a mental health tech. And what really concerns me here on the reservation, and I always, share with the people just sobering up and sober, that I come from a recovery group, been off drugs and alcohol for 40 years. So I've been down a road a piece, and I still get, I still have I'm a veteran, so I have a video chat every week. So I had different therapists, but for me, in Indian country, I mean, we come from a small community, and everybody knows everybody, and the thing now is that some of the people, I know some of it's excuses, but they say, I'm not going to go up there because there's nothing confidential up there. Everything, they know everything. And I heard back, and even some of because our department, it wrapped up in one. It's the mental health and alcohol and drug program. They're one. They're one unit on the Cheyenne River IHS. They're one program. It's called Walk Bear Wash Day, Good River. And that because I worked in the field for I didn't say a long time. I didn't have no schooling for it, but I learned along the way, and I even got sent to mental health unit. But anyway, it's just like I was one of the ones that said professional ethics and consent principles, and the interviewing skills and the clinical supervision, because you really have to know your clientele and even the people that are under you, to really push the professional ethics, especially, I learned along the way that through, being in the field is that, man, you got to be willing to move into this glass house because you're going to be watched. And even your behavior and what you said or how you react, a lot of different things. And, the person coming off the street and seeking for help, they'll judge you. And a lot of them, they come to me and they ask me, this is going on. How come this professional person's come and I had this deal and they gave me some that wasn't really nice of them to say that. And I don't say nothing about the professional business, but I say, you know what? You just have to. There's some people that are, to me, they're educated beyond their intelligence. So they, I don't know, like they become their job. I mean, they that's like they're superior over everything. And I mean, I could see it coming. I could see them individuals coming, and some
Michael,
are great and good, but some, I just dislike. I don't, say it to their face or anything like that, but I just steer from them, and that it makes that profession look bad. I just, that's
Thank you, Michael. I'm going to just step in for a moment and reflect. You raised a lot of good issues about the challenges of ethics when you're in a close-knit community, and the challenges of a counselor, perhaps is even more problematic, more severe than in other type of health providers. So, a dentist or a medical doctor doesn't face all the kinds of challenges a counselor does, all of them working in this small, close-knit community. But we as counselors, when we're getting into people's personal lives, can raise a lot of challenges for us. And ethics also comes into play when you're doing group and family therapy, because there's some issues there that are different than when you're just doing one-on-one. So I'm glad to see that's a high-profile topic from our poll. And Michael's raised a lot of good points about how when you're in the throes of the profession in certain with a certain context, in a certain setting, these ethical issues, privacy issues come into play a lot. Jacque or Nelda, did you want to weigh in on that?
I just say that if people want to read more about kind of the cultural challenge, especially with ethics, the Society of Indian Psychologists commentary on the American Psychological Association Ethics Code is available on their website. And it actually takes stories and relates them to each point about ethics and where there are clashes and how things sometimes don't match up.
So they look at the APA principles and then provide examples
From Indian country that may show the clash between the ethics code and what we have to deal with within the culture.
Mm-hmm. Does APA need to then maybe adjust their codes to some degree?
They are in the process. They're in the process of updating the APA ethics code, and the two editors of the SIP commentary are on that task force.
That'd be an interesting part of a course. So we getting into some of those details and asking people, have these so-called codes been a problem for you or not been well aligned to things you have faced in your community? Interesting.
And I'll get the website address. I apologize, my voice kind of is coming and going.
Excellent. Look for that in the chat. I think you're telling us. Excellent. Sarah, let's go to the next slide. Okay. So a chance for open discussion. We'd love to hear your thoughts. We spent a fair amount of time talking about two types of crises, suicide and trauma. And so, but first up, what do you recall or what do you think was helpful when we talked about strategies to address that difficult situation where a client is expressing suicidal ideation, may have attempted suicide, or unfortunately may have even succeeded? What kinds of things were helpful in our prior presentations? Feel free to enter into the chat box or unmute and share.
I know during that presentation, I talked about some of the apps that are available to use on your phone. We talked about some acronyms that you could use to kind of help you remember the things to check for the high risk categories, some of those risk factors.
Barbara asked, did we mention the role of outreach to help in dealing with that kind of crisis? Now, I think we talked about the importance of support of close friends, family, to help when somebody is struggling with suicide.
Working with all entities in the community, such as hospitals working with clinics or law enforcement working with clinics.
Yes, I mean, when you try to understand what's going on with someone who's suicidal, you may find that they need a resource above and beyond what you can provide as a one-on-one counselor. And so
some of the research shows that people who complete suicide usually have a doctor or hospital visit within 1 month of that completion.
Yeah. Spiritual treatment. Yeah. Connections to spiritual traditions. To some degree, maybe a person needs some specific kind of family counseling, marital counseling. There could be a medication referral needed. Depression can be helped with some medication for some people.
One of the interesting things that I've learned through surveys is that when people are suicidal, they don't necessarily go like to a doctor or to a counselor. People who are trained to deal with who know the resources or learn how to direct a person, that's not their first choice. If there's thoughts of suicide, they speak to their boyfriend, their girlfriend, their friends, or a trusted relative. So it's not, they don't seek mental health counselors or doctors or psychiatrists. That's not the very first line of people who they reach out to. So it's important to know and about resources and how to intervene and guide the person to the help that they need.
Barbara notes it's beneficial to create relationships for the hospital to reach out to the IHS clinics in their behavioral health area to let them know that a person may be in crisis.
Well, and we talked about creating crisis teams made up of those various networks to kind of help provide that network of support, especially, post-vention.
And a crisis team could involve much of the staff in some ways.
And at different levels, like in the schools, in within the tribe, within the school district, you can have them at various levels that then can support one another.
And Jacque, remind us of that great assessment of suicidality. Had a catchy
Sad persons.
acronym. What's that again?
Sad persons.
Yes. Each letter represented a key word in that assessment.
And we sent that out in your resources.
Mm-hmm. And that gets at somebody's psychic feelings of being down and maybe not wanting to go on, as well as it delves into if somebody's thought much about it, how to do it, have they planned, how serious their planning might be. It kind of covers, both the psychological, emotional side, but also with any suicide assessment, you want to see if the person will talk more about how much they've thought about it, because that often is a pretty good predictor. Have I got that right? If somebody's got concrete plans.
Right, the more concrete the plan, the more specific, the more details, the more apt they are to act on it.
Right. I don't know if we talk much about it, but the internet perhaps has not been helpful along these lines.
Especially social media.
Oh, there you go. But doesn't the internet unfortunately fill the gap of somebody's knowledge about how to do it?
Yeah.
You go to the internet and it'll unfortunately give you way too much, perhaps, on this.
It can really feed that downward spiral.
Yeah, it's a good way of putting it.
And Sarah indicates, I'll get an email with the resources from all the previous sessions following this one. So if you missed one of the sessions or didn't get some of that material, you'll be able to get it after this session.
Would anyone like to share, a success where you thought you were very helpful with someone who looked like they were in a suicide crisis, and your good work in clinical expertise help steer someone toward a healthier path?
Michael says their tribe has a recovery house. And one night a week they gather and anybody can come and socialize.
Mhm. Well, that surely can help when somebody is feeling alone and you got an option to.
And we talked, during that session about the kind of the different steps. I think it was the safety card from SAMHSA
Mhm.
that kind of has 6 steps of addressing the crisis. Going from kind of the least restrictive to, more involved with professionals.
Yeah, the more involved can be contracting with a client to keep them up to date on a fairly regular basis, maybe even hourly basis of how they're feeling, or a contract that you always will contact me, the clinician, if you're feeling such and such, before you make any decision or think too far along, let's talk. And so you have a contract for that. Now that puts a little strain on the client and the counselor, but that's that's the kind of sometimes involvement that's needed.
And the apps that can go on the client's phone that can go through and you can actually build them a safety plan that kind of helps when they're starting to feel maybe suicidal or starting to have suicidal thoughts, that maybe they can interrupt that themselves, or they can go places that can help them to get out of that spiral, or find friends that has all these steps for them to intervene with others that may have around them, more so than getting to the last stage of dealing with the professionals. Although I've had some clients that felt like they didn't have anyone except the professional to talk to.
Right. Yeah, that's never ideal. When you have, I suppose, a case like that and you get through the crisis, seeing how the client can build a broad social support network is important, so that you feel like now there's a safety net starting to build for that individual. Michael, thank you for sharing. Any other thoughts from the group?
Anything that anyone remembers from any of that discussion that you feel like was most helpful? Providing safe support to peers, Donna said she found most helpful. Any others?
Just to comment on Donna's point, it strikes me that as a culture, roughly across the board, there is less stigma about feeling depressed, maybe even thinking about how life isn't worth going forward, and thus sharing it with others, or realizing you can express and communicate that to others, perhaps is more open, and there's a greater willingness to do that culture-wise than there has been in the past. But when I was a kid, I think it was something that was stigmatized so much, it was tough for anyone who felt that way to feel like they could share it with somebody, even a friend or a parent. And maybe now we're much better, and we've progressed far. It strikes me that can help bring supportive individuals into that person's sphere, and then provide some preventative medicine, psychological medicine for someone who is feeling suicidal.
Miriam says collaborating with others and their ideas in the chat and seeing different perspectives has been very helpful.
Ah.
And Sarah follows up with collaboration with other professionals has been incredibly valuable, especially on the topics of DEI interest. It's diversity, equity, and inclusion.
Yes.
I have some friends that changed it to a Jedi. Accessibility, justice,
Oh,
equity, diversity, and inclusion. A Jedi.
I thought you were talking about a movie from Star
No.
Wars. Okay. Donna notes it's been taboo for far too long.
Yes, it has.
Yeah. Well, and maybe some of you know the basic survey data that is out there, but when you're a teenager in modern times, you take any group of teens, and I think this has held true throughout several decades. Roughly 30% of teens, you're in the throes of 15, 16, 17, will say that I have thought about ending my life. Now, it doesn't mean they're suicidal or took it seriously, but the so-called normal adolescent experience with all of its, in many ways, minor crises in terms of what a crisis is, can lead a lot of young people to think about, whoa, this is pretty tough. And of course, we struggle as a teen and make our way through it, but it's part of human nature. Well, there we go. Sarah's commenting. Jackie, read that aloud.
Sarah says we actually but the title is DEI. I had a for the DEI has done well.
Yeah.
Very good.
Very good. Maybe Sarah can get your coordinator title changed
To a Jedi.
to a Jedi. I
A
think
Jedi Master.
yeah, that can come with a lot of other responsibilities, but you can make sure that they're not asking more than what's realistic. Pretty good. I missed the one. There was a good one on dual diagnosis. I encourage a friend with a mental disability to start a support group. Anybody with a dual diagnosis. Michael's weighing in on that. Yeah.
And Sarah says, do or do not. There is no try.
Yeah.
Quoting Yoda.
Yeah, there you go. All good.
And then Valerie says, helping to draw out the protective factors a client may have to help them with their resilience, to find the resources that will encourage the support of caring for mental health. Once there's some stability, I like the cultural therapy as a tool to help folks connect to cedar or wool that will help them connect to their inner self for deeper work that can aid their treatment with the client's mental health provider. Thank you, Valerie.
Very good. Yeah, I mean, educating clients with basic, cognitive behavior therapy skills, obviously excellent, but educating clients on how they are an agent of their own support, and they may have to take some initiative to try to build a caring network. The simple discussion with someone about how tough would it be to just go up to someone that you trust and like, maybe even love, and ask them something along the lines of, so can I turn to you if I need to talk about a personal problem? Can you be of help to me if I'm feeling a little down? Many times we don't do that when we wish that we we had a person, and maybe that recipient is more than happy. I think a lot of us would be quite generous with our time if we knew somebody wanted it. But maybe there's a reluctance to be assertive in that way. Maybe we fear we won't get the right answer. But I think it's quite likely many of us have in our sphere of friends and close acquaintances, a lot of people who'd be willing to help out, so provide support. And they don't know that you might want to seek that.
Michael says we have a recovery chat line 24/7.
And
So
Michael,
having that place that people can go, there's 988, there's suicide hotline. There are a number of those types of things available by phone.
would you say 911 and 988 differ in what ways?
988 is focused on suicide and mental health crisis.
Okay.
911 is emergency response, where they're sending police, fire, ambulance.
Mhm. Yeah. So if you had a mental health situation where you actually wanted, though, the police to help out because there might be a risk of violence, let's say. So it's both. Best to call, what do you think? Or dial what?
Okay, run that through again.
Sure. Imagine you're in a situation, not that you're a counselor, but imagine you're personally in a situation where it looks like there's a mental health issue with someone, but there also is a risk of violence. And so you think it would help to also have law enforcement show up to provide security. Would
There's a
988
risk of violence and safety is an issue, 911.
Yeah, go right there. Someone thought 988. Michael said 911. We have a split vote, Jackie. I suppose 988 would know how to help also call law enforcement. They must be trained
Right.
for that. Yeah.
But, it just adds an extra step in there. Now, what you could
Right.
say is call 911,
Yeah.
and then once they're on the way, call 988.
Right. There you go.
But sometimes it's hard to, if you're trying to get help for another person, it's hard to get them on the phone with 988.
Mm-hmm. Yeah. Yeah.
So, it's harder to do that third party type of intervention
yeah.
there.
Well, and some law enforcement are pretty good, whether formally or informally, as I'll call it a mental health aid, an acute mental health aid. Some of them are good at that.
Some are and some aren't,
Yeah.
And some are less comfortable with it and they don't do a good job with it, or they're
Right.
afraid of it
Oh yeah.
and they react with their own issues, things like that.
Oh yeah. Yeah.
But getting them the information that it is a mental health issue
Yeah.
is important in communicating that to 911.
That's a good point.
Some law enforcement groups now have a behavioral health person
On staff.
on staff, or that can respond with the units.
Yes. Yes, they are building networks of social workers within law enforcement. In fact, I think some social work programs are now tailoring some of their coursework along those lines in the hopes that many will seek that as a employment opportunity and find communities that are hiring. Yeah, along those
And
lines.
the whole misnomer of defund the police was really the idea behind it was to develop those supports
Yeah.
that could be a support and respond with police and be sources to take care of those situations,
Right. Be a
as
de-escalating
opposed to just a
agent.
law enforcement response.
Yeah. Well, it'd be interesting. I hope somebody's studying this phenomenon, because I think some communities did embrace that, Jackie. It'll be interesting to see. So some good comments have come in. Rachel says, I think they need to be involved to make sure someone's properly trained that can help responders at least. Yes. And many people have been killed. I'm sorry, I'm going to, I got to click better. Many people have been killed because their mental health episode wasn't considered, especially in minority communities. Yes. Well, you know, this discussion has been around for a long time, but how to try to de-escalate something or maybe neutralize a person who is very violent, looking like they might harm others without having to kill that person with some type of non-lethal force. Nothing's been invented, even you know, rubber bullets haven't worked all that well. I don't think they're used universally. Tasers, you know, can help for some people, but they don't work for others very well. It's incredible how we've had a tough time figuring out, I'll call it the middle ground of preventing someone from being violent, but not having to go to extremes to get that endpoint.
And Barbara indicates that they had some in Wyoming, but they've gone by the wayside because of funding, and it always comes down to money,
Oh,
not what people need.
CIT officer, that would be, what would that stand for? Crisis intervention train
Team?
team? There you go, probably a team, yeah. Crisis intervention team.
Yes, thank you, Barbara. Should we move on to another
That's a good point.
question?
So the next slide is quite similar, just wondering if we're hoping you could share your thoughts on our discussion that we spent a lot of time discussed with the issue of trauma. And so what do you remember was helpful when we discussed some of the crisis intervention strategies and approaches when dealing with trauma? Now, trauma is broad. There's acute trauma as well as more chronic, including historical trauma. But thoughts, comments on that? I know one thing struck me, Jacque and Nelda, was what one learns when they're dealing with a suicidal client, you also could apply in many ways to a client that's suffering from some type of trauma.
Absolutely. Very similar types of situations that you're dealing with. And then as a provider, you may be having a crisis of your own by the time you finish dealing with that situation.
Right. Right. Well, Michael notes the 4 letters PTSD. Yes. So
And Sarah comments that it's very important to address secondary trauma.
Secondary trauma being the
provider.
Yeah, the provider.
Family members, those that are surrounding.
You got it. Right.
Nelda says oftentimes the family of the person in crisis are just as traumatized as the individual in crisis.
You know, one of the things that strikes me with that is how much an external observer, an external person, a loved one, looks at someone in crisis and they realize, I can't control it. You know, it's part of the anxiety and the angst of that is how little you feel that you can influence something. You know, when you're dealing with a personal crisis, you may realize, okay, if I do these 3 things or one thing, I might be able to get better. Of course, sometimes people don't do it, but when there's a loved one looking at someone suffering, you realize there's a helplessness feeling.
And Kimberly mentions thinking about the different how the different traumas interact.
Yeah.
that they aren't just in isolation, that they interact with one another.
I don't know if people written about coexisting traumas, but I think that's what Kimberly is referring to. So if you have a single trauma, does that mean that's all the trauma that you experience? You know, I can imagine no. You know, there's the domino effect.
Well, that's like with the ACEs, the adverse childhood experiences. The more of them you have, the more apt you are to have other health and other related issues later on in life.
Yeah, which at many times can be a trauma. Yes. Yeah, Michael makes a note about to what the extent PTSD might be across the board
Mhm.
in Native communities, among natives. And yeah, you know, as he also mentions, to some degree, and that brings up the point of many psychological issues, behavioral problems are on a continuum.
Mhm.
And mild, moderate versions are very different than severe versions. So, and that can be helpful for people to realize that as well as counselors.
Well, and the same type of event can impact different people in different ways all along that continuum.
Right. The heterogeneity of response to the same event, you know, that shows up even within one family, all biological relatives, and of course the range of responses could be all over the map.
Which is where
good.
resilience comes in.
Very good. I was just
and helping to build those resilience skills from early childhood.
Well, that was what I was just you've read my mind electronically. You picked it up.
It's that Jedi thing.
Yeah, I got to be careful. Something else I'm thinking about you might comment on. How Oklahoma's not going to win on Saturday. No, never mind. Yeah, in fact, we might as well talk about resiliency. It's one of the slides later. And it's been a theme throughout all of the behavioral health talks and all of the installments. I like the fact that while it's very practical when we think about it for clients and trying to teach and support those skills, it's also very relevant to think about it when you're wanting to make sure you're healthy as a counselor.
And we call that self-care.
There you go. I mean, you look at the list of keys to resilience, you realize these are all also can be bundled as self-care features.
And remembering that self-care is not selfish. It's helping to take care of yourself so you're able to take care of someone else.
Yeah, isn't that so important? And also look at the long term. If you're going to burn out, that means there's fewer clients, fewer years you're going to be helping people. So pacing yourself. You know, it must be tough if you're an individual counselor that has your own private practice, because you may not have the network. It strikes me it's a little easier if you're in a clinic, you have a team of counselors, you have a staff, you have supervision, you have a plan for how to avoid staff burnout and how to build resilient skills. Sarah's got her hand up.
Go ahead, Sarah.
Hi there. I'm just really interested in this particular topic within the DEI work that I do at Western. We're working really hard on trauma resiliency, specifically with secondary trauma, with client-facing clinicians and staff. And one of the things that I just really wanted to mention is that it's so much more than self-care. because by the time we do the self-care, it's too late. It's already too late because we wait for the weekend, or we say, oh, I'm going to get a facial at the end of the month, or I'm going to go for a walk with my friends on the weekend. But that's already settled in your cells. It's already settled. The moment that we need to address trauma is that moment when it's in your chest, when it's in your belly, when your breath is taken away. And so it's really worth it to look into somatics and how to get into your body again, because what happens is that we experience the trauma and we think to ourselves, oh, that's not mine. It's not going, I can let it go. But we actually need to do physical things to get rid of it, to really actually get rid of it. And so one of the skills is taken from animals. When animals are under stress, they shake. And so one of the things that I'm teaching staff to do when they feel that first feeling in their chest or their belly and their breath is taken away is to just start really shaking the whole body until every part of you is jiggling, all the parts that you don't normally jiggle, just shaking and shaking and shaking and shaking. And then sitting and finding your exhale all the way to the bottom of the breath. And doing that until you feel in charge of your breath again. And that's just one of the many, many somatic skills, but I just think it's super important to mention, don't wait for self-care. Self-care is great, but do it in the moment. Remind your coworkers to do it, notice it, and actually practice this, because it is life and death. So, yeah.
Do you also teach something that can be done that's just all mental, like a mindfulness 2 minutes, not the physical aspect you mentioned, which is intriguing?
Yeah, I would say 4 square breathing is a good way to get back into your breath. So exhaling,
just spending a
pause.
Yeah.
So it's an exhale, it's a pause, it's an inhale, it's a pause. And you're doing that until your breath comes back. Yeah.
So don't eliminate self-care.
No, don't eliminate it. That's great.
But this is to make sure you get the kind of immediate response and not wait for an important later.
That's right. Yeah. Safety.
Well, I also think self-care can be that,
Yeah.
the whole aspect.
Right.
It doesn't have to just be a one-time thing once a month or something like that.
Right. I think that's how we think of it. Yeah. Yeah. And I think that's just taking it away from like the idea of pedicures and massages and things like that. It's like a moment to moment awareness, self-awareness. Yeah. Thanks.
Thank you.
I know.
And
I don't think
I know
any
with
of us. Go ahead, Jacque.
I know I really, push self-care with my students and all. And, I'd keep fruit and coffee and other drinks and things like that there in the office, and tried to make it healthy things as opposed to, a lot of the snack stuff. And really pushing that nutrition is a part of that care and all of these other aspects in managing their stresses.
I don't know if when we're trained as counselors, we get enough of this. I don't recall in my training that this was part of the importance of being a good counselor. But you realize, if you're not going to be at your best if you have all these lingering issues, and there are, rational. Sarah is bringing up, you could implement something in a 2-minute window and might do wonderful things for the rest of your day. There's also a school of thought. I'm just going back with the resilience theme, a school of thought that it can help when you're growing up, that you have faced some challenges and then learned how to deal with it, and also learned that they can be something addressed, and that you can learn a lot about yourself and help build self-confidence and learn by having to overcome challenges. And those early lessons can serve you well throughout your life.
And, you know, we really didn't think about that for a long time as far as how we teach our children as they're growing up to deal with stresses so that they're, you know, kind of like, you know, how do you handle disagreements in a healthy way?
Yeah. How to argue fairly, somebody's,
Right.
I've seen term it, yeah.
Other things that we teach them to do that will serve them well as they grow up.
Protecting too much with, I'll call it a psychological, social, emotional bubble isn't perhaps the best path. And we don't formally teach resiliency skills. Well, let me go backwards. I don't know how much people are aware of the social emotional learning movement in schools, or life skills that was also part of a lot of prevention programs. To some degree, those are trying to teach some resiliency skills, but I'm all for the more the merrier, because these are great healthy tools in one's life toolbox. Sarah, which is the sixth competency that's being added?
So it's trauma resiliency skills. We want all of our
yeah.
clinicians to be educated and to actually have action plans within their work so that we're addressing this before it happens so that we can really be responsible as an organization. So we've decided that there will at Western be this sixth competency that we expect.
Nice.
Yeah, I think it's really important. It's really good stuff.
Are you guys doing this without peers? Is anyone else doing this?
This is my pilot project here at Western, and my intention is to create trainings that can be expanded across the nation.
Yeah.
So.
Wow, kudos.
So look for that.
Yeah.
Yeah.
Exactly. Well, you keep us up. We're going to invite you to do a webinar if
awesome. Thank you.
to help promote this.
Yeah, please do. I would be very interested in that. Thank you.
You know, that's one way you move changes within practices, is you start at the education level and get people trained along a certain line, and then that, of course, filters its way through. And it takes time. But
are we ready to move on, or do we want to have more to finish up with trauma?
Well, that's good. We've got a couple. Yeah, let's go to the next one. The next two. Oh, yes. So two things came up. Oh, by the way, Sarah is sharing her email for people who want more on her initiative. It's in the chat box. Thanks, Sarah. Homelessness came up with our discussions, but we didn't have any formal content around it. So we thought we'd talk about it now. It was a prominent term in the word cloud as a source of crisis. Wanted to pick everyone's brain that's willing to chime in about how are you or your community trying to address this problem. Are you individually or specifically with your clinical work, or are you seeing efforts in your community? We're interested in your thoughts on this. A chance to put something in the chat box, or feel free to unmute.
Certainly complications to any of the other work that you're doing.
Yes, and it's not just a public policy or a public health problem. Perhaps I'm saying the obvious, but a high percentage of those homeless will meet criteria for at least one mental or behavioral disorder. Substance use is very common, of course, but also are others.
I think many times they're more vulnerable to lose of it, to lose in or have taken from them
Yeah,
any resources that they may have from any benefits they've been able to be connected with,
yes,
which makes them more vulnerable to being homeless.
yes.
Barbara says we have a solutions committee with people from all areas of business and leadership and the tribes. Currently, we're setting up trailers that are close to town to help at least get them out of the cold. Then they can work out other details, medical, mental health, addiction, etc. Thank you, Barbara,
There's
especially with winter coming.
yes. There has been some work, some pretty rigorous research on that strategy. Just getting somebody some basic housing and then having caseworkers work with the individuals on getting connected to the available resources can help stop the cycle of homelessness.
And, Barbara said they were getting trailers set up. I know of some communities where they're building tiny houses, the little bitty houses that, can,
The one room type.
right.
Yeah.
Uh-huh. Kind of like an efficiency apartment, all in a single occupancy
Exactly,
dwelling.
right. Exactly.
But when we ask about what types of crises people had dealt with, homelessness was one of those that had come up in one of the more frequent responses.
As a counselor, you feel like you may not have ready answers and strategies to help someone with homelessness. And if you're in some settings, hopefully there's a broader network of expertise. But if a community hasn't initiated something like what was just mentioned from sorry, I'm missing it was either Stacy or April, where there's been a community response. It can make a counselor feel fairly helpless.
Mm-hmm.
And I know, there are some cities and communities that have shelters, but they can be quite intimidating for many individuals to use. Realistically, there can be a lot of fears of availing oneself of those services. And so you might have beds and space available, but people don't want to use them.
Well, and the other thing to keep in mind is homelessness doesn't necessarily mean living out on the street somewhere. It can also mean you've lost your home and you're moved in with relatives and you've got 3 times as many people living in a dwelling as it was built for.
Good point. So we had the next slide, Sarah, is somewhat related. It has to do with wraparound services. And we were asked in after one of the meetings, what does that term mean? And so we thought we'd look at it now, and Jacque provided a photo that fits this slide. So Jacque, help us out.
Well, this is a picture of Dr. Dan Foster and Dr. Sidney Stone Brown. And Dr. Brown was just awarded the Dwayne Mackey Award last week. And so this was a picture of that presentation. But so much of the time when we talk about wraparound services, and the visual that I get is wrapping that person in the blanket, like they did to honor Dr. Brown here. And so I thought that visual was very representative
Nice.
of what we talk about as far as wraparound services.
No, it's a great metaphor. The security of a blanket, the security of having a community with several services. So how would one define wraparound? Wraparound services. What does it mean to you, to your community? Stacy's weighed in. Thank you.
Stacy says care coordination, continuing care, not letting those we serve drop through the cracks.
Yeah, not dropping through the cracks. Yeah, that's a great way of putting it. And
so many times with the inpatient services being in cities, sometimes hundreds of miles away, they really do fall through that canyon between the inpatient and getting back to the community. It's not just a crack, it's a canyon.
Yeah. Donna notes referrals are keys to building these wraparound services. I gotta believe one big frustration is there's many services available in a community. The caseworker knows how to draw lines to connect the person to the right services, and then there's barriers, long waiting list. Maybe the service doesn't have, I don't know, the kind of clinical friendliness that appeals to that person. Maybe it's too far away, and so there's a transportation barrier. Maybe there's no option for a virtual meeting for various reasons. You know, all these things can really make it difficult. It's one thing if you're in one kind of community where there's a lot of it, and so you don't have these barriers, but then you can imagine all kinds of other situations where it's difficult to wrap the blanket around the person.
Nelda says wraparound services in rural areas are not always formal services. It may include relatives, a trusted uncle, family of trusted friends, etc.
Yeah, that's a really good point. Thus, as we mentioned, perhaps about 40 minutes ago, the importance of working with a client on how one can build their own social support, emotional support network that is within their reach. It's like Nelda says, it's kind of the inner sphere of one's influence. Who are you living with? Who are you friends with? Who do you hang out with?
Rachel says sometimes requires things like IDs, but that person has lost them or had them stolen and hasn't yet gotten replacements. And you need multiple types of identification. It's a chicken egg thing sometimes. And that can, sometimes you have to have an address. And if you're homeless, how do you have an address? Yeah. And I know people in shelters, there's been questions, you know, what address do I put down?
Right.
If I'm living in a shelter, because that's short-term housing.
So to get a clinic to accept you as a client and for them to get reimbursed when whatever mechanism they're using, all these things are needed. And if you don't have it, there's the service, there's the facility able to provide it, but they probably won't because there's a big gap in the paperwork. And if they don't get reimbursed at least enough, then they're not going to provide the service for anybody. Yeah, you can imagine.
And it's so it's helping to connect them up with all of those things so that they don't fall through, or helping them to get that ID, or helping them to move to closer to the front of the line.
Yes. I suppose providing homeless people with relatively inexpensive cell phones could be helpful. No, I mean, and maybe that's just part of the social service that picks up the tab, but you know, a basic cell phone with minimal features, so it's, you know, not expensive. That helps for contact purposes. Perhaps the person can put in the cell phone all kind of information they need to show ID, to present key facts at a clinic, etc. But of course, that can get lost and stolen.
Yeah, and then it's got all their ID information on it.
Yeah, and then right. You
Yeah.
can imagine.
You know, there are drawbacks to all of those, but finding ways that work in your community to provide those services or to help with those
Right.
things.
So Barbara notes some places offer free phones in a service for a year, but I'm not sure who does it here. But the problem is they're cheap phones, as you mentioned, lost and stolen. Yeah. Yeah. When I was working with clients in disaster shelters, providing individuals with a phone was an important step for some individuals. It's all about assessing individuals' unique needs. Mm-hmm. Well, yeah.
And
Right.
we talked about,
Or
you know,
ID.
crises like tornadoes and floods and wildfires and those things. People lose all their documentation.
Yeah.
It's like, where do they start to get help?
Yeah. No, it's, but you'd think that the cell phone world could maybe develop a version of it that's very accommodating to people with some of these life situation challenges.
Rachel says it's almost a need though, because many services can only be accessed electronically. The offices want to text you your
Yeah,
appointment
exactly.
details.
Right. Yeah.
Online check-in too. Yeah.
Right. I mean, it's such an electronic world, and for someone to negotiate it, having access to digital product seems to be valuable, essential. Well, hopefully there's smart people thinking about this and figuring out, you know, there's a whole sector of society that needs electronic access, but we're not building these things yet to think about them. We're always thinking of the teenager and the high-end user.
Do we have anything else? We've got about 5 minutes left, 7 minutes left.
Yeah, Sarah, what our next slide might be what? Oh yeah, just
Okay.
I think we'll end on this this content. We just have a few minutes left, and we surely want people to weigh in with any general comments, but we sure hope you appreciated that we so often emphasize the importance of you and your clinic and your health system being culturally informed, culturally competent. And so what kinds of things do you do to keep up with being culturally informed? What kind of keys do you think are important to pass on to others?
While we're waiting on some of those responses to come in, Valerie commented that wraparound's a great concept to help aid folks in identifying their voice of their needs and goals and connect them with family and friends who might be resources to helping them achieve their needs and goals. Being a good relative as a service provider in a tribal community is so important to keeping folks connected to them and to maintaining their all-around goals. nothing about us without us is a great cultural competency, because our clients are the main source to help us identify what their needs are and to determine what services or trainings we need as providers. Thank you, Valerie.
Yeah, excellent. Getting educated from one's client about all kinds of things is inherent in that great chat commentary. Yeah, so much of what we do is making sure we ask the client to actually weigh in. I know they're often coming to us for us to weigh in and provide the answers, but the answers often are with the client. And some of the art is how you're able to draw that out of a person. And maybe Valerie didn't specifically answer the culturally informed question, but there was an answer in her chat. That is, you can learn from your client how to be culturally informed. I think Donna reflects that. We serve intertribal, so we must ask them how we can best help them. Yeah. Seek that from the community. You know, we probably don't do this often as a counselor, but getting a rating from your client of, so how am I doing? Am I providing or helping support, you know, culturally related answers and solutions and strategies? You know, just getting your client to help you think about it, and getting feedback from the client on this issue. Nelda's good point. Being informed about the population you serve, the community's strengths and unique challenges, and how much is the client culturally involved in their own life, right? Assessing the client on that score. And if they're not all that involved, why? You know, what's going on? There could be, you know, a lot of different reasons for it, and then approaches you take to go down that path of seeing if the client could be more involved.
And
Hopefully
Caroline's,
go ahead.
oh, Caroline says we use, and I may totally butcher this, Kalrikarak, not how not to be ill, mind, body, mind, spirit, and physical, being patient and showing lots of love and understanding.
Wow, that sounds right from native tradition. Any other thoughts from the group? We're down to the last couple minutes.
And Sarah's put the link in several times to the GIPRA, or the evaluation information. So please fill that out before you leave today. Donna says being present is so important. And we thank you all for being present with us today.
Yeah. Thumbs up. I agree. Being present for your community and your clients. Such a valuable tool. And so use resiliency skills so you can be healthy and continue to be as present for as long as possible.
Valerie says our behavioral health provides new hires with a book that's called Lummi Elder Speaks. It's written by a number of our past elders and speaks to a lot about how our people lived. And we have gained approval from our cultural commission to allow the new hires to read these to help them identify some of the history of our Lummi ways. It's nice to know that the new hires are familiar with that history to help develop those ongoing relationships. That's great. And I've worked with a few other tribes that have had something like that. but they don't always share it with the new hires.
You mean elders of tribes are writing down important history and
Right.
and traditions. Yeah, that has to be a great resource for a community.
Any
Well-
last words, Sarah, before we?
I just want to thank everyone for joining us today and sharing your thoughts. We really appreciate those who engage, sharing their different perspectives and experience. That adds a lot to the conversation. So you will receive a follow-up email with this link as well to the evaluation. If you could take some time to complete the evaluation, that helps us inform our future sessions. And you will also receive some information on how to get a certificate of attendance for today. So thank you again for attending us.
Thank you all.
Many thanks.